the way that we estimate the risk of cardiovascular disease is generally using one of these charts. This is the SCORE chart, and what you do is calculate the 10-year risk of cardiovascular events using this chart. For example, we divide the patient into either man or woman, smoker or non-smoker, and then age up here, cholesterol along the bottom on the x-axis, and systolic blood pressure on the y-axis. So for example, if you're a 50-year-old man who is a smoker with a high cholesterol up to 8 and a high blood pressure of 180, then you have a 14% chance of a cardiovascular event over the next 10 years. And you can see as you add 5 years to your age, so the risk increases up to 47% over the next 10 years once you reach the age of 65 with those risk factors. The main hypothesis around the development of atherosclerosis is called the response to injury hypothesis. This cartoon shows a normal arterial vessel. We have here in the middle the green lumen with the endothelial cells, the tunica media, and the internal elastic lamina shown here. The combined effect of risk factors such as insulin resistance, smoking, atherogenic lipoproteins, hypertension, and inflammation serve to affect these endothelial cells and to reduce their ability to function as normal endothelial cells. This has the net effect of allowing lipid to percolate through the gap junctions between endothelial cells and cause endothelial cell dysfunction, shown here in the darker shade of green. The lipid, once it accumulates in the subintimal space, sits just underneath these endothelial cells. The function of endothelial cells is mediated largely by the production of nitric oxide, and this has several important effects in the healthy vessel wall. It has antithrombotic, vasomodulatory, and anti-inflammatory effects. Early atherosclerosis, as we've seen, is associated with the ingress of lipid into the vessel wall, and this is associated with the expression of a number of adhesion molecules by the endothelial cells. These recruit and trap circulating inflammatory cells on the surface, and you can see on this electron microscope image a inflammatory cell here and here and here. They've been trapped by these activated endothelial cell adhesion molecules. Once this happens, once they are trapped, the monocytes are internalized and migrate into the subintimal space, joining the lipid and forming a lipid core. The monocytes differentiate into macrophages and in fact begin to ingest the modified oxidized lipid, turning them into foam cells. The monocytes also have an effect once they become macrophages and foam cells in causing smooth muscle cell migration from the arterial media over here into the arterial intima, and this is associated with a change in the phenotype of the smooth muscle cells from a contractile to a repair phenotype. Initially you can see that both the monocyte macrophages and the smooth muscle cells have a protective reparatory effect. So the macrophages are actually ingesting the modified lipid from the lipid core and reducing the size of the lipid core initially, and the smooth muscle cells are forming a protective cap over the top of the lipid-rich necrotic core to separate it from the flowing blood. We know that macrophages in atherosclerosis have several functions, and we've mentioned some of them already. They express scavenger receptors, and these are the receptors by which they can ingest oxidized LDL. They also secrete chemokines, cytokines, and growth factors, which cause the recruitment of the smooth muscle cells and further inflammatory cells into the plaque. They secrete matrix degrading enzymes, which we'll talk about shortly, which can lead to fibrous cap disruption and plaque destabilization with consequent clinical events. And they also undergo apoptosis, and they can eventually lead to enlargement of the lipid core.